All right, we're back. Rick Mercer style, walking around my basement. Okay, so now we're on respiratory treatments. We're going to focus specifically on the ones, the first couple that we'll see in the course, so module one. So we'll focus on asthma, seizures, and strokes. I'll do another video where I'll hit the last three. Cool. All right. Asthma. So before we talk about asthma, we really should talk about distress versus failure. Respiratory, that is. Respiratory distress, somebody who's short of breath. They're working to breathe. They've got that subcostal or shoulder helping them breathe, belly breathing for the kids, posturing, all those things. Somebody's working to breathe. They still got good LOC and good LOC, and their CO2 is below 50. So this is going to be the real cutoff point to differentiate between distress and failure. Shortness of breath with a good CO2, we think distress. With a high CO2, we'll think failure. COPDers are kind of different, but we'll talk about that in a minute. We'll talk about it in the next video. Cool. So respiratory failure, shortness of breath, working to breathe, all of those things. But they have a high CO2, greater than 50, so high end-tidal CO2. If you can't get end-tidal CO2, they're probably going to be altered, so that's a good approximation. But the actual definition of failure is high end-tidal CO2, they're not clearing gas, with respiratory distress or difficulty breathing. Cool. Once you got that figured out, we're working through asthma. So asthma is a reactive airway disease. Closes airways off, and usually by smooth muscle. There's an inflammatory component as well. We're thinking exposure to pollen, dust, smoke, dirt. Perfumes can do it. Cold air does it to some people. Exercise, happens. Lots of causes for asthma. Often gets diagnosed in kids, but not always. It can kind of show up. And typically when we're thinking more about asthma, we're thinking younger than 40. Older than that, it still could be asthma, but we're starting to think COPD, right? Chronic asthma. Okay, so how do we tell if somebody has asthma? History, they're taking puffers. Oftentimes they'll take long puffers like long-acting steroids or long-acting bronchodilators. And then they have rescue ones, the ones we're familiar with, Ventolin and Atrovent. So they should take their long-acting ones every day or every so many hours, whatever they have. And then when they get short of breath or have an episode, they should be able to take out their Ventolin, the blue ones. Excellent. Now we're also looking at a physical assessment, so we can be thinking wheezes. Asthma closes airways off, they get small, hard to breathe. We'll see those wheezes. Other differentials, COPD, anaphylaxis causes wheezes, fits there. Anxiety is a hard one to differentiate and diagnose, so you've really got to rule out everything else first. Now we're into treatment. So we've assessed our patient. We think they have asthma. We've done our differentials. How are we going to treat it? First line is Ventolin. So MDI, 4 puffs or 4 doses of MDI. I think they're 100 micrograms a go, so you're looking at 400. You can then start looking at a combo of Ventolin Atrovent. So if that first 4 Ventolin doesn't do anything, we can start adding Atrovent. So Ventolin, 4 puffs of Ventolin, 4 puffs of Atrovent. Pro tip, if you're bagging a patient, you can actually, there's a side port, you can push your MDIs through. So have a look at that when you get a chance. If the Ventolin and Atrovent don't work and you've tried 2 rounds of them, so 2 rounds of Ventolin, so 8 puffs of Ventolin, and you've added in the Atrovent and it's not working, we can start to consider this maybe as a near-death asthma. So they got to be really sick, definitely altered, really poor chest rise and fall, having difficulty. In those cases, we can look at IM epi. So it's 1 in 1,000, the small vials of epi, or in the big jugs. And it's IM. Dose is 0.3 to 0.5. Do not give this to older patients, your COPDers. Not appropriate for those guys. And don't do it to somebody who's not. Don't just jump right to that. Always work your way through the process. Some people will say CPAP for asthmatics. Careful with that one. I wouldn't recommend it. It's typically not advised. These guys air trap really bad, so CPAP's not going to work it well. Hospital will use BiPAP. That works. ACPs can show up. We can give mag sulfate. We've got a few more options there. But yeah, PCP level, Ventolin, Atrovent. Do that twice. Doesn't work. We move to epi. Always oxygen as well. Primary survey, we're going to throw oxygen on these guys nice and early. All right, see you on the neuro one.